Well, good morning, everyone, and thanks for having me. I'm Ross. I have a PhD in computational neuroscience, and I'm the CEO of Limbic. So Limbic exists to make the highest quality mental health care available to everyone, everywhere, regardless of who they are or how much money they might have in their pocket. So common mental illness is the leading cause of disability worldwide. And in 2023, we hope that about 1.9 million adults will refer into NHS talking therapies. But these services have a serious challenge. There simply are not enough mental health professionals. So this is an intractable workforce supply problem, and it has downstream impact on patients. You get long wait times, and this can lead to high attrition and drop-off while on the wait list. Patient experience suffers, and ultimately, services incur more costs. So that's why we created Limbic Access, a conversational AI assistant to support mental health triage and clinical assessment in the NHS. The standard practice dictates that a clinical assessment is carried out early on in the care journey by a clinician, and it focuses on gathering clinical information in order to formulate a hypothesis around the patient's mental health issue. Without Limbic, this takes 45 minutes to 1 hour of clinician time. With Limbic, key clinical information is collected upfront by a friendly AI, which then goes on to provide decision support to the clinician. With Limbic, the clinical assessment can take only 30 minutes of clinician time. And this isn't an idea, this is a reality. We are working with 25% of NHS adult talking therapy services around the country. We're interoperable with all the relevant NHS systems, and to date, we've helped 130,000 real NHS patients access care. We also set the standard for clinical safety, and I'm very proud to say that Limbic is the first and only mental health chatbot to have achieved medical device class 2 certification, which really demonstrates our commitment to high standards. The technology is built, real-world evidence is generated, and regulatory approval is secured. So now it's time to scale, and we're requesting £300,000 to take Limbic from 25% of NHS talking therapy services to 80%. And what we need to do is scale up our program delivery team. We need 3 additional people, and we would like to develop an e-learning platform to help deliver a best-in-class staff training experience for our clients. At the moment, we've helped 130,000 patients access care. We think that we can help 692,000 patients with the additional funding, and that will unlock a lot of additional value for the NHS.
If I can ask judges, again, use the raise hand, and I'll take questions in the order they come in. Oh, sorry, we had a few already. Sarah, first of all, followed by John.
Thank you very much, Ross. That's really helpful. I wonder, as you know, this is a market that is quite a few of products similar to yourselves. I just wonder where you see your real USP, really.
Yes, so digital mental health is very crowded. What we have described as this digital front door with e-triage and assessment support, that is comparatively less crowded, but there are a couple of other solutions in the market, you're correct. The differentiation for Limbic is, firstly, we've been in this space before anybody else. And so we've established ourselves and got a lot of learnings on how to implement this technology safely and in order to generate value. And so really, we've been working with, like I said, 25% of NHS IAPT services, which has taught us where all the pitfalls are in terms of taking this from an idea into actually implementing in the real world. The second thing is that because we're a class 2 medical device, and we're the only one to have achieved this level of certification, it allows us to take on some additional clinical responsibility, which means that we're able to formulate a hypothesis, or the AI is, and then ask additional questions off the back of that, which will ultimately go on to narrow down the search space for the clinician. And it really is about that high level of clinical involvement that Limbic is allowed to take on as a regulated product, which can then go on to support the clinician rather than being a glorified data collection tool, which then just passes everything over without any additional analysis and assimilation. Does that make sense?
Thanks. John and then Rod.
Thank you, Ross. A quick one. What's the current revenue and what's the customer segment in terms of condition or age, demographic?
Yeah, good question. So we went to market in the improving access to psychological therapies services. So that's adult talking therapy for common mental illness. Common mental illness refers to depression and 7 anxiety disorders, such as generalized anxiety, phobias, PTSD, panic disorder, these sorts of things. That captures the vast majority of presenting problems, these mild to moderate common mental illnesses. So the revenue, and by the way, is this recorded, and is this going to be shared on the website?
Yes and yes.
Okay, good. So I'm not sure I should necessarily dive too deep into the commercials. We are revenue generating, and we became profitable about 9 months ago, and that's because the technology is built, and a lot of investment went in initially. But now it's a pretty simple economic value proposition in that we are able to save more staff time than the cost that you would have to spend on that clinical hour, rather than the cost of Limbic at our price point, if that makes sense.
Thank you. Rod and then Rebecca.
Hi, Ross. It's really great to hear. I've been doing lots of stuff in and around this space recently, so it's good to see, the development of innovation. We're focusing here, though, specifically on the triage element, right? Not as in once you go down post-triage into care pathways. So we're just focusing about the triage piece. Is that just to make sure?
You're correct. This is the digital front door. Now, aside from this conversation, Limbic does have an in-treatment support tool, but we're not discussing that at the moment.
We're not doing. Okay, fine. So I guess the question is how are you managing, or how are you supporting the downstream by creating, the funnel, adding more people into the IAPT, where we know IAPT is under significant pressure, whilst there is technology and support. How are those NHS organisations reacting to more people going into that funnel, being triaged quickly, but then maybe taking longer for that support?
Yeah, it's a great question. So you've kind of got 2 almost conflicting challenges here, haven't you? At one hand, you want to improve access, but on the other hand, you've got a workforce supply problem, and so improving access just means that they're going to go onto this wait list and wait for them to be taken off. So this was actually the key part of our product design. We needed to make sure that for every new patient we were able to get in on the improving access target, we were able to save staff time internally on completing the clinical assessment. And therefore, that time is freed up so that they can deploy that capacity to treatment. So just to be a little bit clearer about that, as I said, on average, we're saving 15 minutes per patient that enters the service. So 15 minutes of staff time is released for every patient that comes through Limbic Access. And the reason for this is because the information we collect up front and the analysis that we do and the decision support we provide means that the services can compress the amount of time they schedule to conduct a human-led clinical assessment. It would normally take them 45 minutes to 1 hour. With Limbic, it would take 30 minutes to 45 minutes. Okay. And that is proven across 25% of IAPT services now. And I've got some further exciting evidence, which is that in a study across 60,000 patients in IAPT, we were able to demonstrate a statistically significant and meaningful reduction in the time it takes to complete the assessment, as I've just described, freeing up the staff time. But we also reduce the amount of wait time per patient by 7 days on average across these 60,000 patients. So you can extrapolate the impact you could see NHS-wide, 7 days less wait time per patient. If we hit our 692,000 patient target, growing from 130,000, we would save about 13,000 years of wait time in the aggregate, which is...
Ross, that's great. I don't want to cut you off, but we've got more questions. Next, Rebecca and then Chris.
Yep. Well, Rebecca, you're on mute.
Sorry about that. I want to understand a little bit more clearly how far you are in your sort of scale-up journey. I know you said that you've been in or are in 25% of IAPT services revenue generating profitable, but how many of those customers have gone through sort of pilot stage to actually committed, repeatable contracts? Are you willing to tell us?
All these contracts are bona fide procurement rather than pilot. Did our pilot in 2020.
Okay, thank you.
Thanks, Rebecca. Next, Chris Cheney, and then Chris Sawyer.
Thanks, Ross. This is very quick because actually, Rod and Rebecca have kind of asked the question I was going to ask. But just remind us, in terms of your kind of core NHS partners, in terms of your product development, who have you been working most closely with?
So we worked. It was primarily with IAP services. We were originally funded by Innovate UK to do the initial designs, and we interviewed a panel of patients and stakeholders within NHS IAP. Then we did our pilot with a private provider of IAP services to the NHS who had won IAP contracts. And now we are working with primarily NHS Foundation trusts through normal procurement rather than in pilot.
Thanks.
Yep. So just really kind of a follow-on question to kind of several of the other questions. So more business related. What do you need to take the business to the next level, and where do you see expansion opportunities?
Yeah, it's a good question. So, I mean, firstly, I'm here today because I think we can unlock a meaningful jump forward in our business and the impact we can have with an additional injection of £300,000. And that has been the focus of this submission. We're going to scale up our program delivery team and build this e-learning platform to ensure that we can deliver more broadly across NHS IAP. Beyond that, Chris, we are looking at primary care, where 1 in 2 consultations have a mental health component to them. And yet GPs are rarely specialist trained to deal with mental health issues and act as signposters into the IAP services. So if Limbic can establish front doors to IAPs within GP surgeries or within this care ecosystem, we think we can tie together the care systems, save time from the patient going in and then getting signposted, and then release GP time. So that's an area of focus for us at the moment.
Okay, thank you.
Any further questions from the judges? If not, I'd like to thank Ross for his presentation and taking questions.
Hi, so my name's Chloe. I'm the NHS lead for Surgery Hero, who were previously called Sapien Health. We're all about transforming NHS elective surgery waiting lists into preparation lists. Just started out with our story and our why. So again, we're a digital prehabilitation service, specifically for elective surgery. We were founded back in May 2020. And the main reason for that was the acknowledgement from the 4 co-founders that the elective backlog problem was being heightened from COVID-19 and it wasn't going to be going away anytime soon. So the mission was derived from that essentially, and the mission is to help 100 million people have a successful surgery. And why are we looking at this? So why do we feel that this is a problem for the NHS at the moment, as well as something that's been acknowledged within the elective recovery plan and the NHS long-term plan? We're quite aware that there's a growing body of evidence around prehabilitation. So things like alcohol reduction, smoking cessation, diet, exercise, sleep quality, all can have quite a prolific effect on the patient outcomes after surgery. A lot of this research has been focused around oncology at the moment, but there is a growing body around prehabilitation in regards to various different disciplines when it comes to elective surgery. And the problem at the moment is that with the NHS, there's been some systematic reviews that have been carried out. The Centre for Perioperative Care has carried out some research to look at what's offered at the moment. And prehabilitation, generally speaking, is very generic. It's very time limited. So studies show that most patients, if they are offered surgery school at all, are offered one session that can be either 1 hour or 2 hours. And that's just not enough, given that they're then waiting 52 weeks plus to have their actual operation in some cases. Again, that's backed up by stats that 40 to 80% of medical information a patient's given in a clinical meeting is forgotten immediately after. A third of patients go on to have an avoidable complication because they didn't make certain lifestyle changes prior to surgery. And 2/3 of patients do go into their surgery malnourished because they don't have that awareness and understanding, or perhaps that confidence to look after themselves properly. And those NHS pressures aren't going away, unfortunately, with increased staff shortages, A&E problems and challenges, elective surgery cancellations. We feel that it's more critical than ever now that the time and energy is put into that prehabilitation. And this is where we step in. So Surgery Hero is a digital app solution. We're made up of 2 key elements, really. We've got the actual Surgery Hero app, where there's smart tracking, there's peer support, there's personalised surgery content. And we also have what I would classify as our unique selling point. So we have the human health coaching aspect. So that involves a full-time Surgery Hero employee who meets with the patient on a weekly basis to talk through what they're finding challenging in the run-up to their surgery, and if they're needing support with any of these key focus points. At the moment, we are live in 7 NHS trusts and 3 ICSs. So we're supporting around 5,000 patients to date. This is a case study from South Tees, where we focused on orthopaedic patients. We were able to show a reduction of 2 days length of hospital stay, an increase of 10 points in PAM health activation score. 86% of patients completed the programme, and we were able to prove a cost saving of £273 per patient. We're also working with Cheshire and Merseyside ICS. We've been able to show a 2.5-day reduction in length of stay here, 43% reduction in post-op complication rates, 0% of our patients have gone on to acquire hospital-acquired pneumonia, and we've been able to show an 80+ net promoter score as well. And these are just some quotes from our patients that have gone through the programme so far. Thank you.
Hi, it's a hugely topical area, so it's really good to see. My question would be around sort of like the digital inequalities and socio-demographic inequalities of the dependency of digital. You know, I'm a huge supporter of digital, but I just wanted to know roughly, what are you doing to help support people going through surgery that don't have access to digital, don't have access to broadband?
Yeah, it's a really good question, and it's something that we're looking at constantly to develop. So we are working on a web platform. Of course, that doesn't support if patients don't have access to internet in the first place. So what we're doing at the moment is we're quite aware that this isn't going to be an option for everybody, unfortunately, as much as we would like it to be. So we're working with trusts so that clinicians can focus their time and energy on those that they need to see in person, and we can support those that do have access to the digital capabilities. Again, appreciate that that's not going to be suitable for everybody, but by adopting something like Surgery Hero, clinicians are able to focus their time on those that aren't able to use those platforms, unfortunately.
Thanks, Chloe. Next, Rebecca, and then Chris Sawyer.
Hi, Chloe. This is quite compelling because I know there's a real problem in this area. So I really enjoyed the presentation. What I didn't really understand from it, though, is sort of where you are in your adoption journey. So you've done a trial and you've got some stats about the outcomes. But do you have any paying customers yet, or are you at pilot stages? Just give us a little pencil sketch of where you've got to.
Yeah, so with those 7 trusts, they have actually paid for the service. So a lot of that at the moment, it's come from NHSX adoption funding. For example, Cheshire and Merseyside were able to adopt our service through that funding. Our role and our position at the moment essentially is to scale. So I'm speaking with various ICSs and trusts to look at funding our platform from either charity partners, ICBs themselves, to help to bring it in.
Okay, thank you.
Thank you.
Thank you. Chris Sawyer, then John.
Rebecca basically asked my question, but I guess just leaning on from that, it's really about kind of your business model. Is your kind of focus 100% on the NHS and major trusts?
So no, in short, so my role is to look solely at the NHS, and then we've got a co-founder called Matt. His role is now looking at insurers, and he spent quite a lot of time in the States. So we're about to get a deal signed off with the likes of Bupa in the States in regards to private insurance as well. So that's the three main areas: the NHS, insurers, and also the NHS insurance side of things as well.
Okay, so you're looking at
US, sorry, not NHS.
Yeah, so you're looking at expansion outside of the NHS, but you're also looking at international expansion as well.
Yes, exactly. The main focus is the States at the moment.
Okay, that's great. Thank you.
Thank you.
Thank you, John, and then Sarah.
Thank you, Chloe. Just thinking about sort of the size of the health economics use case, what's the main profile of the users? So sort of type of surgical procedure, department that you're in, and perhaps where could the greatest cost saving be found?
Yeah, so at the moment, those that we've worked with, so if I say, for example, South Tees and Cheshire and Merseyside that were in the case study, they were orthopedic and respiratory surgery. We're also working with some more niche areas. So we're supporting Portsmouth in regards to colorectal oncology patients as well. In regards to the largest cost saving, it is quite difficult to say because I'm hearing different things from different clinicians I'm speaking to. For example, some of the London trusts have mentioned that their backlogs are largest with, say, cardiac patients. So they'd like to focus within that area to make sure that the cancellations are reduced and they're getting patients prepared. I'd probably say, just based on where the largest backlogs are sitting from our research, it probably is orthopedic and cardiac. Thank you.
Thanks, Chloe. Sarah.
Thank you, Chloe. I'm interested, you mentioned a little bit about your plans for scaling with sort of rolling out to sort of ICSs and looking at charity partners and things like that to be able to fund. Could you give us a bit more detail on the plans to scale and what would actually enable those plans? What would help you to get bigger at this point?
Yeah, of course. So in regards to our plans to scale, the business has 16 employees full-time at the moment. So our plans to scaling include growing that. That, of course, comes with further adoption. So paying customers, essentially. In regards to how we plan to support as well, it is offering that scale-up service. So what I mean by that is, at the moment, our health coaches, we tend to say it's one health coach can support 100 patients. Our plan is that by the end of the year, one health coach can support 200 patients, and the long-term goal is 1 to 1,000 patients. We know from the work that we've done, speaking with other health coaching companies in the States, that figure is possible, so 1 to 1,000. And that's how we plan to be able to support the NHS on a larger scale. What we're doing to get there is, first of all, making sure that the health coaches' lives is as easy as possible. So essentially constantly improving our tech, making sure that there's automation in there. So members will be getting nudges and things like that. Also constantly improving the AI capabilities of the app. And then with that as well, there'll also be growth in regards to actual increased headcount as well.
Thank you, Christian.
Thanks, guys. It's a slight follow-on from Rod's question around kind of EDI. Yeah, what work have you guys done to think about how you can support kind of ethnically diverse populations? Have you got multi-language capabilities? Your coaching group reflective of catchment populations? Sorry, I might have missed this, but I just wanted to double check that.
No, you've not. Thank you. So we've worked with quite a few private consultants in regards to it to improving this side of the business. Our plans are to increase. So at the moment, it is just within English, the app. Our plans are to bring in multi-language capabilities, especially when we're having discussions with, for example, some areas across the London region. A lot of the population speak Bengali primarily, for example. So that is within our plans. Yeah. Thank you.
Thank you. Claire, I've got a question. In terms of the health coaches, what level of training and professional qualifications do they have currently, and how do you envisage that going forwards?
Yeah, so at the moment, they all have various backgrounds, either dietitian background, physiotherapy background, or wellbeing psychology backgrounds. They do also all go through the NHS health coaching training, and they go through the registered highest level of health coaching training that is on guidelines and boards for that. In regards to their personal background, so as I've mentioned, they do differ from either physiotherapist, dietitians, but we do keep them away from giving that specific tailored advice. For example, if somebody's coming to them and has specific diet questions, we do then signpost them back to their registered dietitian at their trust, so that there's not any mixed messages going on there as well. Thank you.
And one more question from me. You mentioned that 7 of the trusts that you're working with are paid for, and that's paid for by NHSX adoption funding. With the demise of NHSX, is the funding of any of those kind of sites now at risk? How are you kind of migrating to something a bit more sustainable?
Yeah, so with the likes of that funding, that had already been prepaid for. So for example, Cheshire and Merseyside, they have 1,000 licenses essentially that they're working through with us. In regards to sustainability of the business and that model, we have just secured an additional 2.5 million in Series B funding to support our short-term plans.
Brilliant, thank you very much. Any further questions from the judges? No, brilliant. In which case, I'd like to thank you again, Chloe, for coming and taking part today.
Hi everyone, I'm Bahini, CEO and founder of Panakia. Panakia was founded on my own patient experience when I had to wait for 1 whole month for lab test results in context of a cancer scare. And I did the same lab test during my cancer-focused PhD. As a result, we are on a mission to make precision diagnostics accessible to both patients and doctors all over the world, starting with the NHS. So what are we solving? Well, today, in order to decide the right diagnosis and inform the right treatment for cancers, you need to run many different wet lab assays to establish cancer biomarkers. They require a complex process, which takes very long and high cost. What if we could go from something as complex as this to something as simple as this, where you get results at the click of a button in minutes and at a fraction of the cost? That's exactly what Panakia does. Our first clinical product focuses on breast cancers, specifically 3 biomarkers of breast cancers, ERPR, HER2, and offers results in minutes. It's UK, CA, and CE marked, and is the world first of its kind, and is already being piloted within the NHS. This approach is very different from others on the market, as we use AI to replace the need for existing wet lab assays. Our solution aims to improve NHS operational efficiency, patient experience, and outcomes by offering results in 1 click with a 1-day turnaround time for multidisciplinary teams. It can reduce NHS workloads by freeing up to 9,000 pathologist hours per annum every year, whilst offering cost savings of up to £16 million per year. This approach can also help the NHS meet its net zero goals and improve patient experience by offering faster treatment, improved experience, and reduced inequalities in patient outcomes. And that's just for breast cancers alone. Our core technology works across 30 solid cancers. As a result, we are receiving support from NHS hospitals, AHSNs, and the Digital Pathology Consortia. We're also backed by some of the leading UK investors. And we are looking for partners, both clinical as well as investment partners, to help us roll out our product across multiple NHS sites, gaining nice recommendations to scale across the NHS before expanding to other cancers and scaling beyond the UK. And that's the end of my pitch, and I look forward to receiving questions.
Great, straight in with lots of questions. And we're going to go Rebecca and then Sarah and Rod.
Hi, it's absolutely fascinating, but I'm left wondering how you do it. Are you able to tell us any of that? Because those are genetic markers. How do you analyze them with imagery?
Yeah, so the secret lies in my PhD and my postdoc. Essentially, throughout my academic career, I tried to understand how molecular changes to cancers results in different shapes of cancer cells and tissues. So what we knew well enough was that genomic changes, transcriptomic or RNA-based changes, protein-based changes, as well as metabolite-based changes result in different morphology of cancer cells. And there's extensive work going on around that and how to exploit that within a clinical setting. So that's what we leveraged when we built our ML solutions that now identify the morphology and link them to the underlying molecular profiles.
And is that already being done by pathologists? So are they looking at that already? Is that sort of an accepted practice to look at the shape? And
in principle, what pathologists do is look at shape, but they look at different types of biological outcomes. So they don't necessarily, they're not able to identify by as accurately as what ML can do, whether certain types of biomarkers are present or not. But this is also why we started with breast, because when we spoke to Professor Sarah Pinder, she did say that oftentimes ER/PR HER2 expression is correlated with grade. So when people specialize in breast, they're often able to identify whether a cancer is triple negative, for instance, which is absence of all three markers, or ER and PR positive.
Okay.
So there was a histological basis, which has allowed us to build trust within the community.
Okay. I want to ask about data, but I'm going to stop because it's somebody else's turn.
We may come back to you. Sarah, then Rod.
Hi there. My question is about the pilot that you talked about. Sort of how far through and at what point do you think it'll then be ready to become a paid product?
Yeah, so currently we are already evaluating the product across three independent sites, and we have more being onboarded. The goal of each, some of these pilots, let me put it this way, is actually clinical adoption at a local level. So what we're evaluating is how well does it work? What are some of the considerations that clinicians need to have in order to be able to adopt the solution? We would expect to start seeing clinical usage by the second half of this year.
Hi, mine's slightly different. I was thinking more about the user experience. Can you give us like a little flavor of, from first through to diagnosis and?
Yeah, sure. I had a slide, but I will.
We've used your 15 seconds on that.
Yeah, so in essence, what happens currently is when you have a tissue slide, that either gets sent as a slide or it gets scanned in the more modern workflows, and an image gets sent to a pathologist, and they have to visualize or assess the pink and purple pictures that I showed in my presentation to decide if a patient has cancer or not. Once they diagnose that a patient actually has cancer, they have to then submit a request to the pathology lab to run the molecular assays on the remaining piece of tissue so that they can get ER, PR, and HER2 results. In case of ER, PR, HER2, because of the way the wet lab assays are done, there is additional interpretation needed from the pathologist, which happens about 3 to 14 days later, based on when they receive the results. And then that gets discussed at an MDT. With our solution, when the pathologist diagnoses that a patient has cancers, what they have to do is they literally have to click a button or a couple of buttons within the same software that they are using to diagnose the cancer, and they get results as a text-based outputs in minutes. So it's much faster. They make a decision in one sitting, and because our solution integrates into existing clinical workflows as well, it just makes it much more seamless.
Okay. Thank you.
Chris, and then Megan and John. So I've done it again. Chris Shane.
Thank you. It's a question. So obviously, this competition, if you're successful in it, at the end of it, you get hopefully a year coming and working with us at Chelsea and Westminster. I guess my question to you is, looking at how how you kind of set yourself up to date working with NHS organisations, do you feel like you've got the bandwidth to take on more sites at the moment? Do you have the resource to do that? And also, at the end of that 12-month period coming and working with us, would your objective be to actually have a commercially viable product you can take to market? Do you think that's realistic?
Yeah, so in terms of the bandwidth, yes, we do. We do have sufficient bandwidth because our entire focus has largely been on breast cancers. And a lot of the work we do is actually cumulative. So working across different sites will largely include local validation and then supporting the customers in terms of the onboarding. We've already got good experience of that. So some of the studies are already ongoing. So that's I would say a plus. And then in terms of rolling out a commercially viable product by the end of the year, we do expect, we've received the CE mark late 2021. We've already invested a lot of work over 2022 to refine the product to generate additional evidence. And we are quite confident that at this stage, and this is us giving extra buffer, that by the end of the year, we should have a commercially ready product. We should also have the evidence that is needed in order to undergo health technology assessment for NICE.
That leads nicely onto my question, actually, because I was wanting to explore a bit more your regulatory compliance, because obviously you mentioned the CE mark, but it sounds like this is going to require a higher level of compliance than that in terms of medical safety and potential NICE evaluation and things like that. Do you kind of briefly gone over the roadmap there. Do you see any challenges to obtaining that certification, and what's your roadmap to get there?
Yeah, so there are two things. First is we can actually roll out products at a local level without needing NICE recommendation, but it is our preference to receive NICE recommendation. So I think the types of challenges that we see would be more around the level of evidence that we can create, and that's where also having more partners allows us to generate evidence across multiple sites within a reasonable amount of time. I think that would be one of the bigger challenges. The second one would potentially be around, and I think this is slightly alluded to, around resourcing the company, but for that we are backed by investors. We have more funds coming in as well, so we're in the middle of a raise. Happy to share more details on that offline. But collectively, one of the final things that we do need to do is engage the right sort of stakeholders. We've already made some headway on that by engaging members of the RCPAT, members of the Breast Cancer Screening Committee. We've had early interactions with NICE already, but we would love to strengthen those relationships to ensure that we've got pretty much everything as much as possible covered in advance to allow for a smoother transition. I do suspect that there may be gray areas because NICE has newer recommendation around AI technologies and evaluation of AI technologies. So it will depend on how many technologies before ours have they evaluated as well.
John, then Rebecca.
Thank you, Pahini. Is it replacing the need for gold standard ER/PR HER2? Or is it providing earlier insight only? And if earlier, what is the functional impact, sort of in terms of your reduced time to treatment?
Yeah, so the UKCA CE marking are essentially for a standalone diagnostic test. So we reduce the need for ER/PR HER2 testing. We do not, for purposes of clinical safety, the way we've designed our product is, in case the models are not confident, we return an inconclusive result, which means you would then refer to your existing wet lab assays. But that said, we do tend to reduce the need for ERP or HER2 testing for majority of the cases. So there is a significant cost as well as time benefit with even the first version of the product. We can improve that over time as our models learn across more cases and see more diversity.
Thank you. And what is the functional impact of that?
Yeah. So in terms of the functional impact, I think that's a very important question. In the short instance, it's more around driving NHS operational efficiencies. What we do hope to be able to demonstrate over long term is actual improvement in patient outcomes besides just experience. And that especially would be critical in cases of stage 2 and stage 3 breast cancers, where we know that there is even a few days delay can mean a progression across the stage.
Brilliant, thanks. Rebecca, I think you were next.
I apologise if I haven't quite picked this up from the bits of answers, but to my mind, this is essentially a clinical diagnostic, or at least replacing a clinical diagnostic. So presumably you've either done or you'll need to do clinical trials comparing to the existing to prove that you've got the same, you're as good as essentially or better than.
Yeah.
So where does that? I haven't quite figured out where that fits into what we've been talking about there. Have you done them already, or are they coming next?
Yeah, so those are the multi-center studies which are ongoing as a part of the pilots. And in terms of the validation, we see 2 different stages to this. So one is against retrospective data. Because this is an AI technology, one of the big advantages is we can use historic data sets.
Yep.
Then the second piece is the prospective one, where you compare against existing wet lab assays and you look at the concordance. Early results indicate it's quite promising, and that's why we want to show that it works across as many sites as possible, because there's also site-based variations.
But you've designed it so that if there's any doubts, you're passing on anyway. So that's probably okay. And how many patients do you need to do that in either?
Yeah, so in terms of
retrospective and prospective.
Yeah, so based on early power calculations per site, it's we need approximately 350 cases for retrospective and 350 for perspective. And collectively, we've estimated we would need at least about 1,500.
Why do they need to be per site?
Because the way our product is designed is similar to existing wet lab assays, you calibrate for a local site.
Oh gosh, that doesn't.
Which allows us to actually have higher performance compared to what you would have otherwise.
Okay, thank you.
Thank you. Chris and then Sarah.
Yeah, a quick commercial question. Are you looking NHS or just NHS? Are you looking outside the NHS, kind of international expansion?
Yes.
Thoughts on that?
So for currently our priority and our focus is within the NHS. We do have a lot of interest from international hospitals, especially from India and US. And we've had expressions of interest from other countries, but our priority is to get the first product out, and then strategically partner with pharma around expansion of the biomarkers that we can actually offer to cancer patients, and leverage that partnership to roll out across other markets. We already have had quite a few big pharma inbounds around that.
Thank you.
Sarah.
My question was related to the cases that you were talking about there, with the sort of 700 cases you need. What percentage is that? Say if you were to go to Chelsea and Westminster, what sort of numbers and what percentage would you be needing of their population?
Yeah, so that's a very good question. Off the top of my head, from what I remember around Chelsea and Westminster, they see approximately 700 to 800 new breast cancer diagnoses within the network. That on its own should be sufficient. So we can take it from a perspective setting, it would take us about 6 to 8 months. And retrospectively, we expect the data to be there at least 1 year historically. but we know data is stored for 10 years. So the retrospective piece, I'm not as more concerned about. Yeah.
Thank you very much.
That's great. Lots of questions. Any final questions from the judges? Thank you so much for coming and presenting.
Very good. Thank you very much, all. Let me share with you all a bit our vision as a complement to what we have already informed you about. We are quite passionate, and we truly believe it's our purpose, it's our mission, that mobility is going to become a new vital sign. It's already being used as a vital sign. And we want to occupy that space and be its de facto measurement. In reality, when I say we, who are we? Just to highlight in our executive team, I'm one of the co-founders, Ricardo is the other. Then we have two important persons in our executive team. Professor Rui Costa is currently CEO of Allen Institute in Seattle. He's our scientific advisor, he's a neuroscientist. And Professor Joaquim Ferreira is a neurologist, a researcher, a clinician, very prestigious on the Parkinson domain in not only in Europe, I would say, but in the world. Just to give you a short heads up about our evolution, we started, I mean, our expertise, our differentiation is that we can turn with high accuracy in real time patient's movement into clinical insight. So we are movement experts. And in reality, we started with an in-office solution to address physical therapy with biomechanical models. So what we call musculoskeletal diseases. And then we extract that or evolve that to have an app to follow patients in their daily activities. And now with this vision of being the de facto measurement for mobility, we want to break in the US as a complement to the UK, which was our first internationalization market, develop other therapeutic areas. In terms of addressable market, you can see that Parkinson's can be considered quite a niche. When we had obesity and others, the addressable market grows significantly. On the left, you have just US. On the right, when you had Europe and Asia. We give these in a B2B annual subscription for our solutions. We have a mobile app, as I said, a platform as a service, and we address with these two solutions mainly 5 vertical channels. That's our strategic plan for the next 3 years, and then I can develop more with this. In our investment round, we are now entering into a Series A round, negotiating a Series A round, asking for a raise of 4 million, basically to complement the 1 million in equity that we already got on the seed and the non-dilutive grants to build what I've just mentioned. And I guess 3 minutes are gone.
If you need another minute or so, that's fine. So don't worry about running slightly over.
Okay. Now then basically what we want, let me just go backwards. In the NHS or in UK market, we are, I would say, using our Parkinson solution as a start and addressing NHS. We launched the app on last July. We already address a significant number of opportunities. We have currently 30 NHS players that we are talking to, and we start onboarding on Derby University, which is one of the Parkinson Excellence Centers in the UK. So we are onboarding patients right now as we speak. It's important to mention this once we have this UK focus. And now we are opening as well our first contacts to the private sector in UK. It was our initial approach. We have some important pilots with medtech vendors and pharma companies. Most important, the largest deep brain stimulation medtech vendors in the world. We are talking with their teams in US to use our solution to help them fine-tune the devices they put on surgery in their patients. So we are doing some work in these channels. I can develop that a bit more based on your questions.
Thank you very much. So, judges, I think you know how it's done by now. Raise your hands to ask a question. Who'd like to go first? Sarah, you're first, then Chris Sawyer.
Thank you very much for that. Just a question about what is the patient and clinician experience? Sort of how does it work for them, if that's okay?
That's a very critical question. Thanks for asking. In reality, we address 3 different stakeholders with the same products, but giving them a slightly different value proposition. Just to highlight to you that we have these 2 solutions. The mobile app follows the patients in their daily activities, meaning that we can continuously measure, and without any wearables. This is one of the things that distinguish ourselves from competition. In continuum, passively, we can measure the disease progression through the way we interpret their movement, their gait, and in general, their movement, intensity, balance, length, etc. And then the patient doesn't need to initiate that. He just needs to bring the phone with him, and we make use of opportunistically of the sensors that are in the phone. I would say this is the passive part. Then there is an active part still on the patient side, where they can better manage their medication. They are notified about the moments for intake of medication, which in Parkinson can occur 3 to 4 times a day. And then they can report if they took it or not. They have newsfeed, they have a chat with their professionals. They have a stratification part of the app that can help them identify better their conditions, because there are a lot of collateral conditions, urinary infections, depression, a lot of things. All this information, both passive and active, is fed to the platform and can be seen by the clinical teams. So a specialized PD nurse, a neurologist, someone on the clinical team, in Derby, for instance, we are entering on the rehabilitation, physical rehabilitation, and then extending to the nurse and neurologist. And those persons can follow the status of their patients. The value proposition is slightly different in the sense that in a system that is heavily stressed, and with the nurses, several of them in burnout, maybe as any other professional in the health system due to the high demand and short staff, they can, instead of addressing all the patients, they can have a kind of a traffic light and see the ones that have been stable are presented in green. So I don't need to contact them. They don't need to come here to stress more the health system and the hospital and expose themselves to all this hospital environment. But I'm informed as well about the ones that are in red that maybe fall, didn't for 1 week, didn't take medication, or some other parameters that they can define. So this is truly patient-centered.
And that's and that was mobile app across all of the mobiles, is it?
Yes, yes.
Both Android and Apple. Okay.
Yes, so they just need to take the phone with them. But in reality, we have proved that several things. First, they can use the phone in this pocket today, in that pocket tomorrow, it doesn't matter. Our artificial intelligence understand the differences. That's one thing. Second, they don't have to use the phone 24 hours for us to interpret it, how they are evolving. After understanding a bit the nature, the signature of that particular customer, 30 minutes, 1 hour a day, normally they use the phone more, but if they use it at least this time frame, we can gather important information and update the evolution.
I don't want to cut you off, but we've got lots of questions from the judges, so let's move on to the next couple. Chris Sawyer and then John.
Yeah, quickly. Have you measured the outcomes, and what evidence do you have? And do you have paying customers?
Oh, so two questions. We launched the app on July after we got the DTEC clarification and some other regulatory stuff. And then we increased our funnel with the opportunities I already mentioned. Now we are onboarding. We don't have yet customers paying. We are starting that process. That's one thing. Second, we have a lot of evidence. First thing is that we measured our solution or evaluate our solution against the gold standard for movement and the gold standard for clinical terms, which is the movement disorder society scores, etc. And we can translate these metrics, or let's say this movement, into metrics that make sense for the clinical teams. So this was done. We have done it, usability, feasibility. So all these, we have commissioned to set a study that proves that if patients are followed remotely, the payers, which is this third element that we addressed with the same solution, but a bit of a different value proposition, they can save around 30% to 40% of their budgets by reduction on admissions and hospitalizations, because the patients are constantly and continuously followed. So at least we have some evidence here. But now we are generating the use cases, starting with Derby, to prove that in terms of resource management, this is highly effective.
That's great. John.
Yeah, thank you, Lewis. And you touched on this already with Chris's question. What's the key measure of success for the payer? So yeah, is there reduced follow-up appointments, or is it sort of purely complications downstream?
This goes, let's say, this goes in a chain. If the patients are remotely monitored, the clinical teams that are under stress can do a better job, meaning they can address the patients that are in most need. By doing so, there are two effects for the payers. There are reduction in admissions, reduction in hospitalizations. For instance, we have a risk of fall feature in our app. Each time that a patient increased tremendously its risk of fall, and we can check that for several other purposes, the clinical teams are advised that is not in green, is in red for that particular question, and can ask them to go and do some physical therapy or some exercises at home. If they reduce the fall, and we have on other studies proved that there are a significant reduction on the falls, in reality, there are less costs for the orthopedic areas, surgeries, follow-ups, etc. So the payers end up getting more savings from this. On the research management, this is also important, because we know by our discussions with some nurses that they are sometimes questioned about their possibility to work in different regions. And in reality, they are so much in burnout, they cannot accept this. But with this triage, even the payers can remote serve other patients and can better manage their resources. Don't forget that with our tools, we give objective metrics to the clinicians. Today, the alternative is that the clinicians have a patient report that is highly subjective and influenced by the fact that they have this disease. An hospital, Derby, can serve patients in Singapore. They don't even have to see them, which is amazing.
Thanks, Lewis. And either Megan or Chris next.
I'll jump in. Thank you, John. So I'm very curious about how this interacts with other remote monitoring solutions, because obviously you've mentioned this as a sort of additional kind of vital sign in a sense. I can completely see the value of the solution, and you seem to have quite a lot of ability to sort of do everything in one package in a way for certain disease states. But how do you see this interacting with remote monitoring platforms, with virtual wards, with sort of patients who are being monitored for other things potentially? Is there any plan to integrate this solution into other platforms or EPRs, or to collaborate with some of those other people?
Yes, absolutely. It's a good question. We are fully open to that. The evolution of our solutions goes in that direction. With Parkinson, what we are doing is A to Z full clinical approach. So we are regulated to do so, and we provide a lot of metrics that are related to Parkinson, not just related to movement. But by developing, which we did, the kinetics operating system, let's call it like this, the platform, the engine, it's supposed, and we are doing that with this medtech vendor on Parkinson as well, to put our platform to communicate with their platform just on mobility. In this situation, we are agnostic to the hardware. We have these interfaces, so we can collect data and can export data. We don't have that developed, it's true. We are just initiating this process with third parties. but we will have this ability, especially with the platform, to gather all other data, integrated our own, and provide the report back to the ones that may need it. So that's in the plan, but we have not started that yet.
And do you have any plans to sort of share your data with other systems as well? Or is it all kind of bringing data in to what you're doing?
Okay, well, for all these questions regarding data protection, etc., we are data protected by design, because we designed these a bit, the solutions, and developed them a bit few months before the regulatory environment came into force. We in reality can export this data, provided the consent information to the patients is clear, that because now what we do is that you gave me permission for us to process your data on the behalf of your treatment. Then if we have to share to others, should be there. But yes, we can do it, of course, but should be there.
Thank you. Krishani.
A really quick question. Thank you so much. You actually covered, I was going to ask you about falls, and you've already talked about the functionality about monitoring users who are at risk of falls. But would I be right to assume that the product also has a function where if a user actually does have a fall, then that triggers a response from the system?
Well, yes. Let's say we have not designed the system on the fall side we have expertise to do so, but to identify that the patient fall. In reality, if you just drop your phone, the level of acceleration is one, let's say. If you bring your phone with you and then you fall, the level of acceleration is different. We can notify these or understand these and understand if it's just the person that went down to the floor to grab something or if the person falls in reality. But what we try to do here is to have the patient reported an event, because in reality, this is in the patient's process today. The difference is that it's not digital. They write in diaries. So as you can imagine, some days they write one things, other days they write others, and then they report. So what we are doing is that you go to a certain screen in the app, click a button, say, I fall. And it's a patient reported information, but at least it's digitalized, stored, and can be compared with other things. What we can do is, it's one of the thresholds, it's one of the metrics, it's inform the clinical team the risk of fall for these particular patients, and we can see these because of the balance, the gait, freezing of gait, etc., is increasing. So you must act upon the patient. Also giving some latitude of work to the clinical teams and not forcing them to act, because if they are in big burden, they will see the solution something like, oh, it is something to add extra work to my job, which is the contrary. We just gather information and put it in the patient profile. You are notified about a few things. Then if you have some time to act upon them, good. The alternative that there is today, things happen and then they call or send an email and report something quite subjective. That's what we want to change.
Thank you.
Luis, thank you so much. Thanks for your presentation.